We are recording. This is not the one.
All right, it is 8 a.m., so we're going to go ahead and get started. This up here. Welcome to Coplow Rounds. My name is Kelsey Brown. I am one of the pathologists here at Coplow, and I will be taking us through the first two cases. So our first case, a little bit older, tail end of 2025, but good nonetheless. So this is a globe from a 9-year-old female spayed Basenji. And the history we received was that there was mild hyphema in this eye, rubiosis iridis with 360-degree posterior synechia and mild iris bombay. There's an immature cataract and absent menace response and dazzle reflex. They checked yes for glaucoma in this eye, and they said the other eye is normal. And they said this problem has been going on for about 1 month. And then other general medical conditions listed were cutaneous lupus, which was being treated with oral cyclosporine and Apoquel. So here is our gross hemi section of the eye. The optic nerve head should be somewhere down here. I believe I actually took a picture of the other half for this one, so there isn't actually optic nerve head in this half. It's all in the cassette. But same findings in this half. Major thing being that there is all of this kind of salmon pink gelatinous material within the vitreous, and maybe this kind of more tan material lining the choroid. And we can see up here that the iris is kind of adhered to the lens. It is all being just somewhat anteriorly displaced just by all this material in the vitreous. Okay, so we will move to histology of this globe. So we set up perfect. Starting with our subgross. It's really bright. Oh. If I turn it down, will that be a problem for the screen? Is that okay? All right, great. Okay, here is our subgross view of the globe. So we have our cornea up top, optic nerve head's going to be back here. There are some little Sharpie marks made by me. We can ignore those for now. So anterior segment isn't particularly exciting. As I mentioned, lens and iris are being pushed anteriorly just by all this exudate that's in the vitreous. So there's this narrowing of the anterior chamber. As we move back, we can start to see maybe there's some increased cellularity within the choroid and kind of on the epichoroidal surface. So those are cells of some sort, which we will look at a little more closely. And maybe we can see, maybe I can actually focus a little bit better. There are also some erythrocytes within this vitreal exudate, so there's some hemorrhage to some degree. And then this is our retina. It's totally detached. It's a little bit folded and distorted just due to the detachment. We'll look at that a little more closely. And then our optic nerve head is kind of distorted just by this retinal detachment. We'll go closer. Go. One down. All right. There isn't too much to say about the anterior segment. There is a little bit of stromal vascularization within the cornea, which is relatively nonspecific. Here is our iris. We can confirm that there is pretty extensive posterior synechia. So there's this really thick kind of collagenous membrane causing an adhesion between the iris and the anterior lens capsule. And that membrane extends along the lens capsule. This is the ciliary body right here. So it's also covering the ciliary body. And more or less just kind of surrounds the lens as well. There's a little bit of inflammation. In our anterior uveal tract, so in the iris stroma, we can see these little lymphocytes. There are probably some plasma cells in there as well. Kind of a non-specific inflammatory pattern. And then looking at our lens, there is indeed a cataract. So our anterior lens capsule is thicker than our posterior. So back here, we can say that we're starting to get into the posterior aspect of the lens because we have this thin lens capsule. And we can see that that lens epithelium has migrated posteriorly, which is one of our hallmark findings for a cataract. Our other one being that there's this pretty wide liquefaction of the cortical lens fibers. You can find some other areas. We have some areas where they're making these little globules. These are more Gagnian globules, another hallmark for a cataract. And it's pretty extensive in this case. So there's the circumferential liquefaction. We have some little aggregates of lens epithelium as well. All right, moving back. We're going to ignore all the material in the vitreous for a second. And our choroids, the posterior aspect of our uveal tract, is more heavily inflamed, so mostly lymphocytes and plasma cells. As we look on the epichoroidal surface in this subretinal space, we have a different inflammatory population. So we have mostly macrophages with some neutrophils. And in some areas we have this material as well. Right here. So we have this very deeply basophilic, kind of radiating club-like material. So this is what Splendori-Hopley material looks like in the eye. And Splendori-Hopley material isn't particularly well defined what it's totally composed of, but it's thought to be antigen-antibody complexes with cellular debris from our inflammatory cells. We often see it with certain infectious organisms. It can also coat some inert substances as well. But seeing it would maybe cue us to be on the lookout for infectious organisms. If I can move, there we go. Which by happenstance, right next to this little aggregate of Splendori-Hopley material, we do have this fungal hyphae right here. And go one closer. So this is a fungal hyphae. Notably, it has this light brown coloration. So this is a pigmented fungus. We can see in this particular field right here that there is some branching. So there's this right angle branching. In other areas, there are more defined septa as well. I don't know if I'm really picking them out very well in this particular organism. I can move around a little bit to show more of them. Maybe between my dots. Ah, there they are. Maybe a little bit more distinct here. There we go. So these ones have little septa, less branching in these particular ones, so they vary a little bit in how they're looking between each field, but they're scattered all throughout the vitreous and the subretinal space. And then just to finish our tour of the globe, here is our retina, which, as I mentioned, is detached. Due to the detachment, it's just very folded. It's a little bit hard to make out the layers. You can see there's still some ganglion cells here, and we do have this atrophy of the outer nuclear layer right here, which is likely just due to chronic detachment. And then here's our optic nerve head. It's quite distorted just because of the retinal detachment. When we have a retinal detachment, it is a little harder for us to confirm glaucoma. In this particular case, I absolutely would believe that there was glaucoma in this globe. We have plenty of reasons for it. So we have robust fibrovascular membrane formation and synechia. We have a ton of inflammation in this globe. So great reasons for secondary glaucoma in this case. Okay, so we will move to diagnoses. Our major finding is going to be the pigmented fungal hyphae and then the associated endophthalmitis and panuveitis. Infection of a tissue with pigmented fungi that form hyphae in the tissue is known as Phaeohyphomycosis, which encompasses a variety of genuses of fungal agents, and we can't confirm what it is just based off of histology alone. We did offer pan-fungal PCR for this case if it would be clinically helpful, which they took us up on. Unfortunately, it was negative, which would be a false negative in this case. And that's not a particularly uncommon result, especially in cases with fixed tissues. The time of fixation maybe alters how likely we are to get a positive result. So unfortunately, we can't say anything else about who these guys are. If there was any lesional tissue left in this patient, so if the other eye, say, had a vitritis, then they could potentially aspirate and do a fungal culture, and that might yield more meaningful results. But in this case, this is about as far as we can go with determining who these are. And typically, phaeohyphomycosis affects the skin in dogs, but there can be dissemination to other organs, potentially due to immunosuppression. As we mentioned, this dog was on cyclosporine due to cutaneous lupus, so that could possibly be a contributing factor in this case. With the fungi being within the vitreous, kind of the posterior segment of the eye, that is very concerning for systemic dissemination of these fungal hyphae. So assessing for systemic fungal infection was recommended in this case. And that is all I have for this one. If there's any other questions,
Did they
statements.
say anything about the PCR, whether it's more likely to catch things with lots of inflammation or not? A lot of times the degree of inflammation is associated with the presence of PCR inhibitors, and I was just wondering if they had any comments.
No, I didn't have any comments about that. Um,
And the only thing I think we know is that might definitely impact
mhm,
the PCR results is the time of fixation.
mhm,
And the longer the tissue is fixed in formalin, the
mhm,
lower the likelihood of a positive test or a
mhm,
usable test. And unfortunately, a lot of our cases come from clients from all over the country
mhm,
and even abroad. So it's almost guaranteed that this tissues will be fixed in formalin for a long time.
mhm. That said, we have had positive results that we
Yeah.
believed were true positives. So something that we still offer, but yeah, there's the caveat that a false negative is possible.
What
Yeah.
were those immune complexes?
It's called Splendori-Hopley material. It's kind of a mouthful. All right.
Is it really blue in the eye because of our stain here, or is it really blue in the eye because of the eye? So these two
Actually,
things were
I don't
just-
think it would be our stain because in other tissue. So the question was the Splendori-Hopley material, is it really blue in the eye in general or due to the stain here at our institution? And that's a good question because typically Splendori-Hopley material is brightly eosinophilic in other tissues, which I'd say at our institution we see it as
Yeah.
brightly eosinophilic in other tissues. So I suspect it's not our stain and eye
Yeah.
thing. I don't know if I have any other insight to shed on that.
And no, I've seen them mostly very basophilic like that in the eye, but we also seen them eosinophilic too, or anywhere in between.
Mhm.
Not the first time we are asked this, and I don't know how to explain that.
Yeah, it's weird, right?
It's helpful though.
It is.
Yeah, as we got a sea of neutrophils, degenerate neutrophils, and then you got this corona of blue. It's almost like a blinking arrow towards there's something in
Yes.
there
Look
that's
here.
you know what I mean? So just for the pathologists out there, not that you need to know that, but well, if you're beginning, big clumps of Splendor Hopley in a radial form, be suspicious of something right in the middle.
All right, great. Move on to the next case. This one, I don't have gross photos because we just got little bits of tissue, but we did get these lovely clinical photos. So this is going to be tissue from a 14-and-a-half-year-old male castrated domestic long hair. We got a very vivid description for this one. So this is going to be from the right eye. The clinician described marked swelling of the eyelids, conjunctiva and nictitins, which precluded further view of the globe, which I can believe seeing what we see here. They said the tissue is dense and firm. Apparently at the RDVM, they had treated this as an abscess, which apparently did resolve at initial visit, but then was cooking again at the time of biopsy 1 month later. The clinician described a nasty odor and purulent discharge and said the material looked almost caseous like rabbit pus. And they questioned if it was even tissue, which I totally understand. It does have that kind of look about it. So they took a punch biopsy of the upper lid region. We did get some haired skin. And then they also took a snippet of this conjunctival tissue kind of deeper in here.
Just to follow up on the Splendor Hopley thing, sorry.
Oh, yeah, of course.
Kelsey Bright wrote that at MSU is blue also in that. So
Awesome.
yeah.
Great.
Thank you, Dr. Brayko.
Yeah, we have an N of 2 institutions.
Right. And then she said that basophilia fills all the residents with consternation also. So you're not the only one.
Well, good.
I appreciate it.
You can commiserate a little bit, Mark. Okay. We'll go ahead and move to pathology. So already a low power of these tissues. There's a great explanation for why the tissue was friable, and they also mentioned it didn't bleed very much when they biopsied it, and there's a great reason for that. It being that there is just insane degrees of necrosis. So all of this is just necrotic tissue, where we have loss of our differential staining. It's just kind of this sea of eosinophilic shmoo. But as we move around, perhaps we can find more meaningful section, which I definitely dotted, and I scratched on the cover slip. Perfect. So here we have that haired skin punch biopsy. See, here's our epidermis. We have our dermis, And then we have kind of our deeper dermis and kind of subcutis region. And as we go closer, let's go straight into our deeper dermis where we have a cellular infiltrate that is relatively homogeneous. I'll just spoil now, this is a neoplastic infiltrate. We have this homogeneous population of round cells. They're just forming sheets, more or less effacing the normal dermal collagen, separating it out. Go one closer and stop scrolling around. So round cells, we can kind of see their distinct borders in some areas. They have a little bit of eosinophilic cytoplasm, these pretty bizarre looking nuclei. Sometimes they're round to oval, kind of the standard look for nuclei, but sometimes they have these little indentations. This one's like horseshoe shaped and maybe has like a little baby nucleus next to it. Just a lot of kind of wackier shapes where they're twisted and indented. Yeah, a little Pac-Man. That's what we call this, the Pac-Man phenomenon. Nuclei have a coarsely stippled chromatin, and we have 1 to 2 prominent nucleoli. And there's a good amount of atypia here. So we do have some degree of anisokaryosis, so different nuclei size, as well as anisocytosis, so some differences in cell size as well. And this is also pretty mitotically active. So here's a mitotic figure here. Going up here, this is technically a mitotic figure. That's pretty bizarre. It doesn't know what it wants to be. And just moving around, there's typically at least 1 to 2 mitotic figures per high-powered field. So mitotically active. And as we go deeper, we just hit this area where there's just, extensive tumor necrosis with some sparing of our tumor cells around vessels. So they're still getting some degree of oxygenation, while the rest of these ones have just outgrown their blood supply. So we provided the very helpful diagnosis of malignant round cell neoplasm in this case, and recommended IHC, which I have to show. You can look at it with me. So we did IHC as well as PAR in this case, which we always hope will be helpful. What's that?
Which did you do first?
IHC. I like to say that this was a very logical flow of IHC and PAR, but it was somewhat disjointed and a little clumsy, as some of these cases go, unfortunately. So here is our CD20, which is a B lymphocyte marker. And there's some areas where we have some good internal positive controls. So in the more superficial dermis, we have these scattered round cells that have this brown membranous to cytoplasmic staining, which in this case, because they're scattered, they're smaller, they're kind of away from the main neoplasm. These could just be non-neoplastic B lymphocytes. As we go into the bulk of our neoplasm, there's kind of this vague background staining, but it's not particularly convincing, in my opinion.
Much darker on this screen than it is in this field.
Thank you. I agree. So yeah, unfortunately, was not particularly convinced by our CD20. CD3. So here's our CD3, which is our T lymphocyte marker. Again, kind of more superficial dermis. We do have this smattering of cells. Turn that on. That have this strong cytoplasmic labeling. Again, could just be non-neoplastic T lymphocytes. Going a little bit deeper into our neoplasm here. Still, for the most part, negative. There is one region. Let's see. In one of our little SNP biopsies of the conj, where there's occasionally these areas where cells did have more convincing positivity, perhaps. And they do have these kind of larger nuclei, so thought perhaps this could be a T-cell lymphoma, just with pretty patchy immunolabeling. So we had PAR performed, and our results, I don't even know why I'm bringing them up, so remember them, was that there was a clonal immunoglobulin gene and polyclonal T-cell receptor gene. So we also performed a MUM1 in this case. Oh, this is the cat.
It's a marker. You use CD79.
Did not do a CD79, just a MUM1. So did a MUM1 in this case. MUM1 is a transcription factor, so our positivity should be in the nucleus. We do have some cytoplasmic background staining in this case, but also strong nuclear staining, and this is pretty similar to what our positive control looked like too. So we took this as a positive result. That combined with the clonal immunoglobulin gene, we interpreted this to be a plasma cell neoplasm sorts. There is a somewhat recent paper demonstrating that a subset of plasma cell neoplasms in cats and dogs can show aberrant CD3 expression, which maybe would explain just the patchy CD3 positivity we saw in some areas. It was pretty rare, but it was there. So go to our. So I ended up calling this a plasma cell neoplasm. In terms of prognosis in this case, it's a little bit hard to say without full staging in this patient. So this could be a solitary plasma cell neoplasm within the conjunctiva, so plasmacytoma, which has been reported in cats, or it could be part of a systemic plasma cell neoplasms like a myeloma-related disease. So we recommended full staging in cats. That would include what you would do with dogs as well. So you'd be looking for bone marrow plasmacytosis, paraproteinemia or monoclonal gammopathy, osteolytic lesions, proteinuria, and in cats specifically, there can also be visceral organ involvement, especially in the liver and spleen, have been shown to be popular places for plasma cell neoplasms to inhabit. If it is solitary, it's a little bit hard to prognosticate because there just aren't that many reports of it. There's one recent retrospective showing that solitary plasma cell tumors in the conj of cats and dogs can have a good prognosis, but there's only one cat in that study. So I think it's a little bit hard to draw much from that. In this case, bottom line is just patient staging is strongly recommended in this case. And we did ask for follow-up. I haven't heard anything back about this cat, but hopefully we'll get some information.
It's a really ugly presentation.
Yeah.
For plasma cell tumor.
I agree.
The ones we see tend to be more like the classic nodules.
Agreed.
Like, like a histocytic lesion type thing, like, tenuous histiocytoma. This is very weird.
Which in my comment, I also underscored. I said in the solitary conjunctival plasma cell paper, in the one cat, it was a very well differentiated plasma cell tumor, which is not like our case.
Yeah. I mean, we see stuff like that in cutaneous plasma cell tumors in dogs when they're solitary or multiple, but not in cats.
Yeah. So it's a somewhat surprising one. We definitely thought this would just be a slam dunk lymphoma case, but yeah, interesting.
I would, I suspected it would be CD79A negative. It seems like that's more commonly expressed in cats than it is in dogs. So
Cool.
Interesting.
If there's money for that on one of these, I think
do it. Yeah. Cool. All right. Well, if there's no other questions, concerns, thoughts, I will slide over and let Dr. Miller take the scope.
All right. Keep the fun going. Our next two cases. So this is the right eye from a 2-year-old female spayed domestic short-haired cat. The ophthalmologist described clinically that they saw a fibrin clot in the eye with extensive posterior synechia with iris bombae. They saw a pink mass within the pupil that they were concerned was maybe either neoplasia or possibly fibrin with vessels. 3+ flare, and they were not able to see the posterior segment in this globe. They do say that this has been going on about 3 to 4 weeks, and they make a note that it possibly occurred after fighting with another cat in the household. Dum dum dum.
It's all fun and games.
It's all fun and games. Yes. So here is our hemisection of our formalin fixed globe. So we can see that there is some like tan to maybe gelatinous material here in the anterior chamber and pupil. We can see our iris leaflets coming here, kind of looking like they're maybe adhering to the lens capsule itself. So there's some posterior synechia. And then our iris is actually bowing into the anterior chamber, maybe a little bit even over here. So that is consistent with iris bombae. So the aqueous humor is being blocked and it's pushing on the iris going forward. The lens is a little bit cataractous, and we can see sort of this cloudy material in the vitreous that's kind of centered right on the lens. So we'll take a closer look at what we got. So starting with our subgross view. All right, so cornea at the top. We can see some of that bright pink material in the anterior chamber here. We could see how that would have looked like a little fibrin clot in the pupil. Here is our iris leaflets. They are looking a little bit more bluer than usual, so there's a cellular infiltrate in there. And again, it's a little bit more obvious on this one, but we can see that the iris is sort of adhered to the lens capsule and it is bowing forward, so that posterior synechia with the iris bombae. We can see that the lens capsule is maybe a little bit irregularly shaped here at the back, and there's some extra blueness. So some cells in, again, more proteinaceous material. And here's our retina and optic nerve. That retina is a little bit detached as well. So let's take a look. Things. All right. All right. Coming back up here. Here's our cornea at the front, was relatively unremarkable. So again, here's our iris. We can see some fibrovascular tissue here. Spot. That is extending between the iris and the lens capsule here, causing that posterior synechia. We can see blood vessels lining the surface here of the iris, so there's a pre-iridal fibrovascular membrane as well. We've got lots of cells in here. If we look at them a little closer, we can see that they're consistent with little neutrophils here. So there's a lot of neutrophilic inflammation in the iris and in the posterior chamber here. It is quite centered on the lens, which is an important feature in this case. And then again, we can see that bowing of the thinned iris stroma here, consistent with iris bombae. And if we come over here, just going to take a look at our lens a little bit closer here. So as we head towards the back of the lens capsule, you can see it's a little bit thin. We've got epithelium lining starting to migrate posteriorly. So that's an early sign of cataract formation. We can also see some degeneration and liquefaction of the lens fibers, as well as neutrophilic inflammation within inside the lens. So that is indicative of a lens capsule rupture. And if we follow our posterior lens capsule, you can see all those neutrophils in the vitreous. If we keep going, here we go. We have this lovely little break here in the posterior lens capsule. And we know that is a true in vivo break because it has sprung and coiled up on itself because of the elasticity of the lens capsule. So we can tell this from say an artifactual break in the lens. Again, we've got some lovely more ganglion globules in lens degeneration and all those neutrophils. And so we're very highly suspicious of an infectious etiology here. Here's the other end of that lens capsule rupture. Boing. And in these cases, we find that it's a lot easier to find our infectious organisms if we head away from where the inflammation is. And so if we head towards, in this case, the equatorial lens capsule and lens cortex, we see that there's a lot of bacilli in the lens cortex. So we've got some bacteria in the lens, possibly implanted there, say from the housemate as well. And we can actually see them. They're pretty extensive if we keep going.
That's gross.
It's pretty gross, yes, but pretty cool to find. Sometimes they're really hard to find. Sometimes they're cocci. We've had a couple cases or a fewer number of cases that there's fungus instead of bacteria in these cases. But this sort of
Depends on the fauna and flora of the cat's nail.
yes.
Litter box.
Culture the litter box. Yeah.
Culture the litter box. Yes. And then we have our retina back here. It's a little bit detached. There's some wrinkling in here. There's a little bit of inflammation in the optic nerve. in the optic nerve head as well. And then something that I didn't show from subgross is that we had another radial section of the globe where the iris bombae was a little bit more prominent grossly. And just as an aside, since we don't have the lens in section here, we can still tell that there's posterior synechia based on like the shape that the iris is taking. You can tell that it's kind of conforming to the shape of the lens. So where it would have been posteriorly synechiated, new word for you, to the lens capsule. And again, that iris bombae. So sometimes the lens can artifactually shift during processing. So even though the lens is not in this section, we can definitely still confirm that there is posterior synechia, although it was very prominent in the main section of the globe. One thing that I did forget to mention during the gross examination of this globe, we noticed that there was a very slight limbal divot at the 2 o'clock position in the globe. And so I trimmed that in. And lo and behold, we do not always catch the defect in the cornea, given how sharp and precise cat claws are. But here it is our Descemet's membrane. And similar to the lens capsule, we can see that there's a sharp demarcation here and it's curled in on itself here. And so here is a peripheral break in Descemet's membrane, which is probably likely the site of trauma.
Where was it?
Dorsal medial limbus 2 o'clock-ish position. And then I did a PAS for fun just to sort of highlight that break. Because again, it is not uncommon for us to not capture the break in Descemet's. So here's a lovely example of that. And there's maybe even some regrowth starting to occur, some doubling there. It did say 3 to 4 weeks duration, so.
I mean, a jab, a hook.
What was this name?
This was the right eye. Yeah. Right hand strike.
Cross.
Yes. So again, all these features in this case kind of line up with what we call septic implantation syndrome, which again is a rupture of the lens secondary to a previous penetrating traumatic event. This trauma introduces bacteria into the lens and results in an endophthalmitis that is quite focused around the lens itself and within the lens. All of the features seen in this case. Our most common traumatic event in these cases is a cat claw injury. So it's also nice to have that little piece of information in the history provided to confirm that as well. And again, we don't often catch that peripheral break or any breaks in the cornea with these cases because they can be very small, but we happen to catch it in this case. So it was a nice.
Another interesting thing about these is the timeline. It's variable. The history is usually there's a more acute bout of endophthalmitis or uveitis, usually right when the traumatic event happens. And then there's bacteria that gets seated inside the lens. So that happens in dogs and cats, both. So the animal will recover from that initial bout of uveitis and be well for a little bit while the bacteria is brewing inside the lens. And then after a period of time, you have a more expensive cataract, and then exposure of the lens and the bacteria, and then there's a secondary bout of uveitis and endophthalmitis that becomes unresponsive to treatment and develops glaucoma. So the timeline between the trauma and the time the eye gets nucleated, can be relatively long in terms of months, weeks. So having that history is also useful.
All right. And then the next one I have is a real quick one. This is a 3-year-old male intact mixed breed dog. We have the kind of the front-on view of the globe on this side. This is the right globe, and then our hemisection on this side. And hopefully you can make out that in the cornea is this brown foreign material. And this dog suffered a penetrating trauma to the right eye while at play with its owner, and they had a stick lodged into the eye. So that is what this brown foreign body is here. Cornea is a little cloudy. You maybe can catch there's a little bit of the tip of the stick here, and maybe it looks like there's a little bit of disruption to the iris here, which was noted on the gross exam, that the lateral iris was penetrated by a 4 millimeter wide stick that kind of extended laterally from the perforation site. And then we said that the lens was a little bit subluxated. So briefly, I will give a little view here. Globe is upside down. There we go. Ta-da! So pretty dramatic here. We have an abrupt defect here in our cornea. We can see this sort of brownish looking material here that extends through the cornea into the anterior chamber. A little bit of fibrin and some neutrophils associated with it, and then a pretty quiet rest of the globe. All right, so yep, a pretty big stick. So again, very sharp demarcation here. Here's one end of Decimase over here, another end over here, and we can just see our plant material that is stuck within the globe. Yes, I will polarize it. Give you some pretty colors this morning. Ah.
The goal or mag seal.
Look at it go. Yes. I need like 5 extra hands here to be doing all this. There we go. Sorry. There we go. Ooh. So pretty nifty looking. We can see from this low power here that there's kind of this little sharper demarcation, like indentation into the iris. So again, where the stick was coming through and probably at least touching, if not maybe penetrating the iris as well. And if we go back and look at our stick, our plant material often brings little friends with it, and this is no different in this case, where we have some lovely fungal hyphae and little like Canidia yeast bodies along for the ride with the stick. And I think there was even some bacteria here and there as well. So bringing all in its own fauna here as well. So, and again, it was very acute. I think they said it was an 8-hour duration, so they brought the dog in very quickly. Just a little bit of hemorrhage and some fibrin starting with neutrophils, thinking that they're going to try to take care of this.
Give it their best.
They're going to give it their best. The lens itself was intact, at least in the examined sections, so there was no evidence of lens capsule rupture in this case, so it seemed to have missed the lens, but otherwise it was just a nice little example of an acute stick in the eye case, some acute corneal penetrating trauma with that foreign body and a little bit reaction to it. So with that, I will make way for Dr. Clements.
And why we switch presenters, just a shout out to our clients. We love our clients. They just send those cases. I mean, there's no doubt in the diagnosis here. There's a little state coming off the eye. They saw everything. But that said, there are also a lot of potentially useful information you can get out of doing the pathology of an eye like that. Imagine you've got this eye and there's are obvious signs of this genesis that might inform how you would follow up on the other eye, or we have found all sorts of non-associated background lesions in these cases. But anyway, I'm very glad that we had the chance to see things like this.
Awesome.
Really cool cases, indeed. All right. So I'm Megan, and I'll do some more cases. This one is an 11-year-old spayed female terrier mix. I love the history on this one. They describe absolute glaucoma. Absolute glaucoma. They say severe corneal edema. There's also an incipient cataract in the other eye. This was an acute onset with signs consistent of glaucoma, including maybe a little bit of enlargement or corneal edema and pain, although Booth-Almas is more of a chronic glaucoma thing, typically. Let's see. There was a high suspicion of underlying cataract and uveitis. And we'll leave it there. So on the gross view of this eye, one of the things that's most striking is we have the iris here, this brown line, and then on top of the iris, there's this really, really thick tan carpet. It's probably also along the back of the cornea, although the delineation of the cornea is actually kind of hard to see. The cornea is quite thick, it's quite opaque, pretty abnormal. We can imagine that probably there and there we have the advancing border of vascularization extending into the cornea from the periphery. The vitreous is full of this cloudy gel. So usually when the fluids inside the eye gel up like this, it means they have a very high protein content as they hit the formalin. And then the lens is just sort of hanging out, sort of fading into the background a little in this cloudy stuff, but is looking a little bit cloudy itself. All right. That's got some fuzzies on it. All right. Still got fuzzies. Oh well. So on the subgross, the cornea resolves itself a little bit better. We can see that it ends here. We again have these very robust vessels advancing into the cornea from the periphery, which kind of matches what we saw on the gross. And most of what was making the cornea kind of blend into all the stuff is this high protein and very cellular intraocular material in the eye and vitreous, and a very purple iris in particular, which implies that there's a ton of cells in there. Right, our cornea has rotated 90 degrees clockwise. As we drop in on this globe, we can already see these huge amorphous globules of pink stuff, which is of great interest, and we will look at it closer in a hot second. And we can look and see this really purple iris, and in particular, it kind of has like a very layered look. It's like a parfait. We've got the melanocytes of the iris itself in the middle, and then it's sandwiched between all of these invading cells. So let's start by looking at the cells that are lining the surfaces of the iris and contributing to that tan carpet effect. Indeed. A lot of these way on the absolute surface are macrophages. The absolute surface, yes. And they're kind of epithelioid looking. Basically, they have layers kind of like an epithelium, like an epithelial layer, so we call them epithelioid macrophages. And then they're associated with a few neutrophils down here, and then stacked on top of tons of lymphocytes and plasma cells. And a lot of this between the iris and the intraocular surfaces is just fibrovascular membrane on both sides of it, which is also infiltrated by inflammatory cells, as well as the iris stroma itself over here, which is inflamed. And if we look closer at this eosinophilic globular stuff, it basically might remind you of the lens if we move over here. And this is a really fun effect with this lens. So for example, here we have all this eosinophilic globular stuff kind of glomming onto the outer lens capsule. It's like a solar flare. It's kind of pretty. And all of these little globules distributed out into the vitreous. If we look around, oftentimes globules of what I will reveal is lens protein dancing around the subject will sometimes have little holes in the middle. Not always in this case, but sometimes they look a little donut shaped in dogs. But otherwise, just kind of globules of bright pink. And we know this is lens protein.
Lava.
It's like a lava lamp, yeah.
You shake it up.
You shake it up, yeah. It might go back eventually. You just have to leave it still for a very long amount of time, right? Anyway. So you can also see these cells here, probably both neutrophils and macrophages phagocytizing this material. So you can see intracellular lens protein in these cells.
This is a beautiful example of it.
Yes.
And just so everyone's aware, we will not always see that dramatic liquefaction and exposure of lens like this. So
this is a large quantity of lens protein. Yeah.
Massive lava.
Yeah. You can confirm cataract in this eye. So there are these big areas of liquefaction in the cortex. There's a little bit of mineral here. There's more ganglion globules. These are swollen and degenerate lens fibers, these globular-looking things inside the lens capsule. And ultimately, if you look all around the lens, there's no obvious defect in the capsule. There is this spot sort of up front, maybe, where it gets like thin and frayed. So it's interesting. Like maybe it's thinking about breaking, or maybe it's broken somewhere else.
Even there, the layering is mostly exudative material rather than the lens, not a,
this.
Yeah, that could look that kind of looked like a ruptured lens capsule when we were looking far away, but that's beautiful.
But yeah, like it's a thinned capsule, but it's not obviously discontinuous. It could be discontinuous out of plane of section. So this is an interesting case. We call this asynchronous uveitis, formerly asymmetric uveitis. The asymmetric was just to indicate that it's sort of an off, it's in both eyes, but it doesn't happen at the same rate and the same way in both eyes. But asynchronous was suggested because it's kind of more of a chronological difference between the eyes, and then ultimately the presentation is the same in both by the end. So the epithelioid macrophage carpeting in particular, so epithelioid macrophage carpeting along the internal surfaces of the eye is what suggests to us this pattern of essentially phacoanaphylaxis or just really, really severe lens-induced reaction. And the key reason why we make a distinction and call this something special, asynchronous uveitis, is that that pattern of epithelioid macrophage carpeting tends to show presentation with severe lens-induced uveitis in the other eye down the line. So essentially finding that pattern is a warning to us that the other eye might go bad like this, and potentially putting the dog on anti-inflammatory therapies, particularly if there's already a cataract in the other eye, as there is in this case, may be very helpful. Some may prefer to call this essentially phacolytic uveitis, if you want to use sort of a less specific term. So keep in mind that there is phacolytic uveitis and phacoclastic uveitis. Phacolytic uveitis is leakage of lens protein through an intact lens capsule, which theoretically this is. I at least didn't find any overt rupture sites in this case. Phacoclastic is when the lens capsule ruptures, and you have a lens-induced uveitis associated with that. If it helps, I remember it by phacoclastic, sounds like blast, like it exploded. But anyway, I don't know if that helps everybody. But we would strongly recommend warning about the other eye and at this particular pattern. The immunology of the lens probably has more to be learned about it. I always think about this paper that got published where they purposefully traumatized rabbit lens capsules. They did not see much of a lens-induced reaction. So, the idea is that lens proteins are sequestered during development, and therefore are like very antigenic, like a hugely antigenic stimulus. And that generally holds true, but it does seem like depending on like how the lens protein gets exposed and how much of it gets exposed, maybe it's unclear. Like the degree or the severity of the lens-induced response does seem to vary quite a bit. So there's probably more to be learned here. This is just sort of an excessive, over-exuberant lens-induced reaction.
Immunogenic.
Immunogenic.
Yeah.
What I say?
Antigenic just means that it can be recognized by the adaptive immune system. Immunogenic means that it is.
I see. Immunogenic. I meant to say immunogenic.
You'll see use the word anaphylaxis in there.
Yes, phacoanaphylaxis is often in a quote unquote.
Yeah. Can you say a little bit more about that? Whether it's a true anaphylactic reaction?
It's probably not a true anaphylaxis, no.
Yeah, that's borrowed from human medicine, which when you read what they meant by that also doesn't really quite fit well with the term anaphylaxis.
Yeah.
So it's a matter of like just trying to compare with something that's already been published, even though it probably wasn't used correctly to begin with.
Yeah, it might be more accurate to just describe it as an overexuberant lens-induced reaction or something along those lines.
Hypersensitive reaction to lens material. Maybe.
So. Events, there we go. All right, sort of the descriptive part of the diagnosis and then the sort of name the disease at the bottom. There aren't any other questions or comments? I'll squeeze in the last one. Totally squeezable. We can squeeze a whole horse into the last 10 minutes, right? Squeeze away. So this is a 20-year-old Lusitano gelding, and I'll show you the gross photo. So this is a small globe for a horse. You can compare to the measuring stick down here. And indeed, the main description of this eye is that it was thesical. So thesical with a relatively clear cornea and a deep anterior chamber that appears quiet. They said hypermature cataract and posterior sneak at 360 degrees, which all fits with the gross exam. Deep anterior chamber, here's the limbus up here. Iris kind of down here. The lens or iris is looking pretty stuck to the back of all this material here, which looks like a hypermature cataract in the lens. And it kind of is. We'll take a closer look. And then a globe that is small and maybe a bit of wrinkling of the collagenous tunic with some intraocular fibrosis. We've got this filmy membrane overlying the choroid, for example, here, mostly probably collagen deposition. And so that's consistent with your thesis bulbi. Interestingly, this horse is now bilaterally enucleated as of this eye being enucleated, and we have quite a lot to learn from both of these eyes. So I'll withhold the diagnosis on the first eye for now, and I'll probably focus on just showing you this one. But
is that the second one that we see?
This is this thesical globe is the second globe.
Okay.
So initially, yeah, this was a quiet eye. They enucleated because they were worried about ongoing pain in this patient. But the first globe was the main one that was enucleated because there were kind of sort of more active problems. All right. Do our best to do an effective subgross. The big slides are always difficult. Can we do this level? That's never as good. All right. So fuzzy. Here's our cornea, our deep anterior chamber. You can see corpora nigra, so cute. Poof. And then here's where our lens should be. It's lens-ish, lens-esque. We do have a bit of capsule here, for example, that we can see even from low magnification. But we'll take a closer look at this because it doesn't really look like there's normal lens fibers here. And then kind of coming down, we have the optic nerve head here, which is looking a little bit stretched. We have maybe some purplish tissue, which doesn't really look like retina, but it's coming forward like this. We'll take a closer look at that too. And that's mainly what I'll show you for now. Let's look at the closer view. Cute little lymphoid follicles in the conjunctiva right as we drop in here. Lymphoid follicle, lymphoid follicle. The conjunctivitis is not what we're most concerned with. So I'm going to focus first on the lens, I think. We've got these pieces of lens capsule, and they are pieces. So it's a pretty fragmented lens capsule. Even though we don't necessarily see that lovely curling effect like Jamie showed us, the fact that these pieces of lens capsule are essentially embedded in fibrous tissue confirms that these are true sites of rupture. If you look even closer, oftentimes these bits of lens capsule, are brunescent or sort of yellowish. And I would imagine this is most likely imbibition of like blood breakdown products. This might have been kind of chronic hemorrhage at some point, but it's kind of long since been cleaned up. And there's really no recognizable lens fibers anywhere in here. It's all just collagen, the occasional fragment of mineral debris, and there's actually also adipose tissue in here. Look at that. Little bits of fat here. This is really, really chronic thesis bulbi. Sometimes you get some interesting kind of mesenchymal tissues deposited, maybe associated with some of the pluripotent cells in the eye. I'm not exactly sure why we sometimes get some weird stuff, but bone and fat are not necessarily uncommon in kind of a chronically traumatized eye, or especially a chronically traumatized lens. But yeah, so we've got all this collagen, all this fibrosis inside the eye, and just fragments of lens capsule kind of stained by what was probably hemorrhage long ago. And some cholesterol clefts, which might be chronic breakdown of phospholipid membranes on these cells. So, old injury is what this suggests to us. Lens capsule rupture is, in terms of spontaneous lens capsule rupture, it's most common in intumescent cataracts, which there's not really going to be a whole ton of instances where you'd see an intumescent cataract in a horse. The most common time that we'll see it is diabetes in dogs. So oftentimes if there's a lens capsule rupture, otherwise we think about trauma. So let's keep looking at this eye though. If we zoom in on the iris, there isn't obvious pigment dispersion per se, and it's half misty here. Hang on a second. Let's try this leaflet. There's some fuzz. Oh, you're reading it. That's true. The source of the fuzzies perhaps has been identified. That's much better. Here we go. But there are occasionally these clusters of melanin-laden macrophages inside this eye. So here's an example of these round cells laden with melanin. If we look really close, sometimes peeking through all that melanin, you can imagine that some of them are multinucleate even, which we sometimes see. You may have to put on your imaginoscope for that one, though. So those are there. There's also very, very rare at this point. If I can find one or two or three. Maybe you'll just have to take my word for it. There are very rare clusters of lymphocytes and plasma cells. There aren't many. Here we go. Here's one. There's a few. It's not exactly the hottest uveitis you've ever seen, but there is some degree of uveitis as it is histologically defined. So we have lymphocytes and plasma cells.
Sure, it's uvea at this point.
It's uvea. There's ciliary body epithelium over here. This is officially ciliary body stroma, just a little bit stretched out. So there's a little bit of uveitis, not much, very, very subtle. And it consists of lymphocytes, plasma cells, and especially in the iris melanin-laden macrophages. In addition, if you go over here to the ciliary body surface, these stretched out plica that are being tugged on by all this intraocular fibrosis, there's a ton of this material directly on the ciliary surface. It's extracellular, it's maybe kind of finely fibrillar looking. And it's pink eosinophilic. So this is most likely amyloid, and I had hoped to have a Congo red stain to show you by now. Not quite. I do have a stand-in for you. So of course the only Congo red that was readily available to me was a case in a horse that was much, much more subtle than this one. But I can still demonstrate the coolness. Wait, if I can find the actual sections. Here we go. Upside down. Apologies for that. So this one we did a Congo red because it was so subtle in the first place, but you have a little bit of a similar looking material, especially on the tips of the ciliary body plicae. In this case, there was actually a little bit of similar material. I don't make anybody ill while we move around like that. Maybe in the trabecular meshwork, if you throw a Congo red on this one. You can see that lovely brick red result, which is a positive result. Same over here in the trabecular meshwork, similar deposition. And then the part that I love to do, and so does everybody. Everybody loves polarization. Wait for it. Dang it. There we go.
Yeah.
Apple green.
Or ocean blue.
Yeah.
Apple green birefringence. Very pretty. Yeah, it's a little bit weird because of the nature of this polarizer. Here we go. That's better.
I'm trying to show that.
Yeah, I can briefly. So
Just ask. Got 1 minute.
I've got 1 minute. Okay. I'm being given the time. So there's amyloid in this eye is the point. Actually, so yeah, let's switch really quick to the other one. And basically the main finding in this eye was also not exactly the hottest uveitis you've ever seen, but again, occasional melanin-laden macrophages, basically pigment dispersion of the iris into macrophages. And there should be occasional clusters. Wait for it. Well, there are breaks in Decime's Hobstria, but the pigment on the back of the cornea might be a little bit more subtle. There was occasionally pigment on the back of the cornea. So the diagnosis in the first eye was a suspicion for heterochromic iridocyclitis, sometimes referred to as heterochromic iridocyclitis with keratitis, but we don't always see the with keratitis part, which is a condition described in a 2015 paper, and it seems to be primarily a pigment dispersion with melanin-laden macrophages phagocytizing melanin. Horses may sometimes even clinically develop depigmentation of their irises. So that's kind of a mysterious lesion. And the interesting thing in this individual and in some other horses that we've seen, there's also the amyloid carpet in the thesical eye only. There wasn't amyloid in the first eye, which I can put something up while we're talking. Yes. What final slide? Oh, diagnosis. Oh, just put the diagnoses up. Yeah, that might be worthwhile too. Let's just do that. There you go. So the amyloid carpet over the ciliary body is interesting. It's most typically associated with equine recurrent uveitis. If we're trying to diagnose equine recurrent uveitis, the amyloidosis is the most consistent finding. We also sometimes see linear inclusions in the ciliary body epithelium, and we sometimes see an actual uveitis in terms of lymphocytes and plasma cells infiltrating stroma. But those are kind of plus or minus. The amyloidosis is the most consistent thing. But increasingly, we've had cases that have overlapping features of heterochromic iridocyclitis, and the amyloidosis of ERU, which kind of suggests that maybe the amyloidosis inside of horse eyes is a little bit less specific than we think. It may just be kind of a chronic inflammation thing. But for now, if you're doing tests or whatever, it's currently kind of amyloidosis on the ciliary body surface is pretty classic for ERU in horses. So interesting kind of multifactorial case, probably trauma on top of uveitis in the horse eye, the recently enucleated horse eye that we just saw, the thesical one. Any questions?
Do we know,
Because
is
we're
it
probably done.
amyloid A that's getting deposited, or do we know what type of?
Do we?
Can't remember from the top of my head. There was even
Me either.
discussion at some point if it was amyloid or not, but I think that's passed. I think that's definitely amyloid.
Hmm. Yeah, not all that is congophilic is amyloid, but generally Congo red is a good test for amyloid.
That was angry.
AA?
Yeah.
Kelsey says she thinks it's AA.
Thanks, everyone. With
Yeah,
everyone in
double
there.
checks.
See you guys in a couple weeks.
Okay. Stop recording.
The Jake papers things say.
AA. Okay.
Yeah.
Just the fish, I think.